Frailty, a Geriatric Syndrome by Suzanne Norwood, East Tennessee. Frailty is a geriatric syndrome that has no concrete definition. It's been defined as a clinical syndrome when 3 or more of the following criteria are present: unintentional weight loss of 10 pounds in the past year, self-reported exhaustion, weakness based on grip strength, slow walking speed, and low physical activity. It's also been defined as a syndrome of physiological decline in late life, characterized by marked vulnerability to adverse health outcomes. Regardless of the chosen definition, frailty is known to be the hallmark geriatric syndrome that inevitably leads to other geriatric syndromes. These include incontinence, delirium, falls, and fractures. A little bit of background on frailty. According to the World Health Organization, an estimated 25 to 50% of individuals over the age of 85 are considered to be frail. Prevalence of frailty in any given community can range anywhere between as low as 4% to as high as 59%. Prevalence increases with age and is found to be greater in women, in those with lower education levels and low income, poorer health, and those with higher rates of comorbidities and disabilities. Frailty is significant because individuals that are frail are at a higher risk for adverse health outcomes, including falls, hospital admissions, disabilities, and even death. Frailty is expensive to healthcare. Identifying frailty early with regular screenings can reduce healthcare costs by decreasing the number of hospitalizations and institutionalizations. The identification of frailty is crucial to the nursing profession in that it can be reversible and with proper interventions, including nutrition and exercise. My patient that I did my comprehensive geriatric assessment on is an 80-year-old female, currently a patient in the skilled nursing facility post left total knee replacement surgery. She is normally in pretty good health, but over the last 2 years has had some pretty serious health issues. She usually lives at home with her husband, who is in good health and shows genuine interest in her health care and is very helpful. 2 of her grown children and grandchildren live close by, and she sees them often. She's active in her church and has a strong support system. My patient has an allergy to codeine, stating that it causes nausea and vomiting. She has no known food allergies and no known environmental allergies. My patient's current medications include the following. Her prescribed medications include Arimidex, a 1 mg tablet, 1 tablet by mouth daily, Xarelto 20 mg tablet, 1 tablet by mouth daily, Metoprolol 50 mg tablet, 1 tablet by mouth daily, Digoxin 125 microgram tablet, 1 tablet by mouth daily, Prolia 60 mg injection, 1 subcutaneous injection every 6 months, Metamucil 1 to 2 teaspoons in 8 ounces of water, 2 to 3 times daily as needed for constipation, calcium citrate 200 mg tablet, 1 tablet by mouth daily. Her over-the-counter medications include Tylenol, a 325 mg caplet, 1 caplet as needed for mild pain or fever, Unisom 25 mg tablet, 1 tablet by mouth at bedtime as needed for insomnia, Mucinex 600 mg tablet, 1 tablet twice daily as needed for chest congestion. The patient is current on her immunizations, including influenza, pneumonia, shingles, and tetanus. She's up to date on her health maintenance screenings, which include a colonoscopy, a mammogram, bone density scan, a pap smear in 2005, but she does not plan on getting any more due to her advanced age, yearly hearing and vision screenings with her primary care and ophthalmologist, and regular well visits with her primary care physician. The patient does have quite an extensive past medical history, including chickenpox and mumps as a child, osteoporosis with history of fracture, atrial fibrillation, hiatal hernia, estrogen receptor positive breast cancer, diffuse large B-cell lymphoma of lymph nodes of the neck, non-Hodgkin's lymphoma, protein-calorie malnutrition, anemia associated with chemotherapy, chemotherapy-induced thrombocytopenia, leukopenia, syncope, fatigue, stress fractures in back and feet. She has a surgical history including esophageal manometry, a robotic Nissen fundoplication, laryngoscopy with biopsy, modified neck dissection, right mastectomy, right total knee replacement, left total knee replacement, and a tonsillectomy as a child, but the year is unknown. She's been hospitalized for her hernia repair, cancer in 2000, 2016, and 2017, her mastectomy in 2017, new onset atrial fibrillation, joint replacement in 2010 and 2019. For her social history, she's a former smoker. She quit in 1963. She does not consume alcohol or illicit drugs, and she is currently residing in the skilled nursing facility but lives at home with her husband. She's independent in her ADLs and her IADLs. Common presentation of the frail patient can include any or all of the following: weight loss of 10 or more pounds in a year, memory loss, weakness, dizziness, depression, or inability to take care of themselves. Frail patients often have complaints of exhaustion, weak grip strength, low physical activity, and slow walking speed. Risk factors for frailty include older age, lower education level, current smoker, current use of hormone replacement therapy, African American or Hispanic ethnicity, unmarried, depression or use of antidepressants, and cognitive decline. The review of symptoms of the frail patient, not necessarily my patient, but a frail patient in general, might include fatigue, unintentional weight loss, shortness of breath with exertion, muscle weakness, slow walking speed, decreased or weak grip strength, cognitive changes, and depression. The physical exam findings of this patient were as follows: blood pressure 139/71, heart rate 63, respiratory rate 14, temperature 98.6, O2 96% on room air. The patient is 63 inches tall. She weighs 103.8 pounds, and her previous weight was 101 pounds. Her BMI is 18.38. Pertinent positives identified for this patient upon interview and physical examination, taking into account the risk factors for frailty, include a low BMI, which is considered underweight and places her at higher risk for mortality, decreased bilateral grip strength, slow walking speed, kyphosis, remote history of stress fractures, and advanced age. Pertinent negatives for this patient include no history of depression or antidepressant use, no evidence of cognitive decline, she is not a current smoker, she is not of African American or Hispanic ethnicity, and has no recent history of falls. I used 5 screening tools in the assessment of this patient. The Frail Questionnaire Screening Tool, which is a quick assessment of frailty, was completed. She scored a 2 on the Frail Questionnaire by answering yes to 2 of the 5 questions. Are you fatigued, and loss of weight greater than 5% or 10 pounds in a year? This score categorizes her as pretty frail. The Tonetti Gait and Balance Assessment Tool, a fall risk assessment for elderly patients, was also completed with this patient. The 2-part assessment includes a balance section and a gait section, and each section has scored items, and a combined score of both of these sections determines the fall risk of the patient. This patient received a combined score of 23 of a possible 28. This score places her in the moderate category for risk of falls. And since frailty is often concurrent with cognitive decline and or depression, a mental status exam and a depression screen should also be completed when screening for frailty. The mini mental status exam was completed with this patient, and it's an 11-task scored questionnaire with 30 possible points. My patient scored a 29 of a possible 30, indicating that she shows no signs of cognitive impairment and has decreased odds for dementia. The patient also completed a geriatric depression scale, short form. This is a 15-item yes or no questionnaire with a total of 15 points. The patient received a score of 1, which shows there is no indication of depression at this present time. She also completed the mini nutritional assessment. It's an assessment tool to identify patients that are malnourished or are at risk for malnourishment. It consists of 6 questions and it also incorporates her BMI. She scored a 7 of possible 14 points, and this indicates that she is malnourished. According to these tools, depression and cognitive impairment are not indicated. The patient is, however, at risk for falls, frailty, and she is malnourished. Additional tools that can be used to screen for frailty include the physical frailty phenotype, the clinical frailty scale, and the study of osteopathic fractures. For labs and diagnostics for this patient, we ordered a CMP, a CBC with differential, magnesium, TSH, PTT, phosphorus, vitamins B12 and D, LFT, and albumin, and these were ordered to rule out reversible vitamin deficiency or metabolic conditions that place the patient at risk for frailty. There were no radiographs warranted at this time since she's had her mammogram and bone density scan recently. Since this patient is up to date and current on all of her recommended immunizations, none were given nor ordered at this time. The current diagnoses for this patient include osteoporosis, anorexia, protein-calorie malnutrition, and she is considered to be pre-frail. All of the patient's blood work came back within normal limits. Results of her DEXA scan that she received in 2017 confirmed the diagnosis of osteoporosis. Differential diagnoses for frailty include hyperthyroidism and depressive disorder with loss of appetite. Hyperthyroidism was ruled out by a TSH of 3.76, which is within normal limits, and depressive disorder with loss of appetite was ruled out with a negative depression screen. Treatment of a frail patient would include the following based on the assessment of the individual. The areas of risk that were identified for this patient were falls, and we would address this by encouraging participation in an exercise program that includes Tai Chi and yoga for osteoporosis, reviewing her medications, Arimidex, metoprolol, Prolia, and calcium citrate all can contribute to her risk of falls with hypotension, fatigue, lightheadedness, dizziness, confusion, drowsiness, and bradycardia side effects. Malnutrition would be addressed by including a nutrition consult as part of her treatment plan, instructing her to keep a log of her food and fluid intake as well as her sleeping habits to bring to her next visit, including caloric and protein supplements in her diet, and reviewing her medications here as well. Her Arimidex and Mucinex can contribute to malnutrition with the side effects of altered taste, anorexia, and nausea. We would discuss in depth her medications and which ones can possibly contribute to increasing the risk of falls and malnutrition and how to avoid them. Monitoring her lab work for vitamin deficiencies and anemia. Challenges to this plan could include the lack of availability of the resources suggested, and a lack of adequate finances for these resources could also be a challenge. The interprofessional care team for this patient includes primary care provider, orthopedic surgeon, physical therapy, oncologist, nutritionist, cardiologist, ophthalmologist, and home health and occupational therapy might be included for a frail patient if they were needed. Community resources for this patient includes an exercise facility that offers Tai Chi and yoga for osteoporosis, and a nutritionist consultation. This patient has positive health behaviors that include medication compliance, regular well check visits, current immunizations, and she is up to date on all of her screenings for her age. She also has positive social determinants that include a strong support system and a safe living environment. Socioeconomic issues that can affect frail patients include low income, low education level, and lack of access to available resources, or even the lack of resources available. Legal and ethical issues involved in caring for frail patients include early identification of frailty and recognizing reversible causes, and not making a frail diagnosis based on the assumption due to age. In my research into frailty, I learned that patients meeting the criteria of over the age of 70, chronic disease, and unintentional weight loss of greater than 5% in the last year should all be screened for frailty, and this should include cognitive and depression assessments. Identifying patients early in the spectrum of frailty can aid in its reversibility. Positive patient outcomes result from goal-setting approach to care, and interventions for the patient should be tailored to the individual.